Thank you so much. How many of you have actually dealt with a CT scan or an MRI scan at a hospital and gone through a prior authorization process with you or one of your families? And you probably understand how painful that entire process is. And that's essentially what we are starting out to solve. We call it a DAMIA prior authorization, which is a co-pilot for your care team. What we did is we started putting together a team that understands healthcare, that understands artificial intelligence, has experience in selling to enterprises, has an experience in building small startups. That's kind of the team that we basically put together. A few of us are in the room. And what we are trying to solve for? We are trying to go after the $265 billion opportunities, a $1 trillion healthcare spend. I think the folks from Microsoft talked about it. A quarter of it potentially wasteful spend. And if you really go down to the wasteful spend underneath it, what you find out is most of it is high leverage knowledge workers, nurses, doctors, doing work which is essentially information retrieval or summarization. And you probably guess where I'm going with that. And everyone starts thinking about healthcare from a clinical perspective, from an administrative perspective, but what we are thinking about it is from a human perspective. It's like, what if? What if the providers that you will go to had really more time to be present at you? My wife is a physician, and we see that every day, kind of like the amount of paperwork and the administrative work she has to do, not because, and that obviously takes away the time that she can be present with her patients. And that's kind of the what if we are trying to solve for from a very human perspective. What if providers could be more present when they are meeting, when it really mattered? And we're starting with one problem, which actually is, in some ways, is a necessary friction in the health ecosystem, but it's frustrating for everyone, right? The physicians hate the prior authorization process because they're spending way too much time. Their care teams are spending, like the nurses, the care assistants are spending a lot of time around it, as well as pharma companies cannot get their latest innovations to the hands of the patients. The payers don't like it. We have spoken to payers, and they don't like it because most of them actually get approved anyways after a couple of rounds. So for them, it's an expense, but it's still a necessary evil, and how do you actually make it work? And if you really go down to the next level and you think about what is the care team at a provider, that's kind of where we started our focus on. What are they doing? Yes, the physician is actually spending the time, but then it's both their nurse navigators, it's their receptionists, and if you go and look at it, most of the time that they're spending is looking at collecting information, checking for validation, and preparing information and sending. It's a lot of information retrieval and a lot of summarization. So let's make it real. Let's kind of quickly go through a demo of what does the DAMIA prior authorization copilot look like. So if you go and look at it, here's a nurse that is going to go and look at, here's a list of prior authorizations that need to go after. And one of the big challenges is these rules, like these are different patients of different payers, and these rules change all the time. Actually, almost a third of the prior authorizations don't even need a prior authorization. It's just that we are dealing with old information, it's never fresh. So we essentially have kind of codified and looked at all the payer portals and their information, connected it to a link, and then we are able to check it. So, and it will auto-determine the eligibility of whether you need a prior authorization. Second, the second, as you talk to the nurses, you understand the second broad area, which is a big problem, is different payers have different requirements of what is needed to make it real, to get a prior authorization approved. So in this example, you see, the 3 documents are mandatory, but then if you add the diagnostic results, or if you add the scientific evidence, the prior authorization chances increases dramatically. It's actually an ML model. It's an ML model based on looking at the history of kind of what actually has happened with that payer-provider relationship. And then obviously there is the most time-taking part, if you ask a nurse, is actually putting together a letter of medical necessity, the LOMN that they talk about. And that essentially is scientific research, and if you think about for oncology, for rheumatology, more complex cases, you have to essentially put together a lot of scientific research to kind of justify where in the care continuum this person is and why do you need why do you need this treatment that you're recommending, an MRI scan or a CT scan or whatever. And that's essentially is where generative AI kind of comes in, where we embed and it always gets auto-created. And obviously there's a human in the loop. There's a kind of a cross-check and balance. There's some guardrails that allows them to go and look at the LOMN and edit it as necessary, talk to the document with a chatbot kind of a feature, or straight away edit it. And then you actually go and then it's obviously integrated with physician notes. If it's integrated with the EHR systems with diagnostic results, and essentially you can go and submit it. So that's kind of the DAMIA platform. And if you try to go and help the nurse, if you think about what does our Copilot differ from the other kind of all the Copilots we talk about, we focus on the individual. We want to make the individual successful, not a task successful. We want to make their role successful. And we want to make the nurse the hero and want to make sure they get time back. And when you go and get time back, or you automatically are much more efficient. 80% more capacity that you are able to generate, what are you going to do with it? You're going to spend that with your patients. You're going to do things that really matter. And how are we kind of going about doing it? We have a strategic partnership with UC Davis out here, who are our co-validation partners. We are testing with, obviously there's a whole host of payers, as well as providers, nurses, and provider offices we have been working with to kind of design this. One of the other big issues is integration, Epic integration. And so we have done a partnership, so we are not reinventing the wheel. We are doing a partnership with a company which already has all the ecosystem of the Epic connectors built out. And then, last and not the least, we are talking to one of the Fortune 10 healthcare distributor companies who actually already goes to these doctors' offices, so that as a potential go-to-market partner for us, and it's an enterprise SaaS kind of a pricing model that will allow us to do that. And just a little bit more about how does it actually happen. It's the kind of the DAMIA platform that we have underneath it. If you really summarize it, it's a knowledge repository at the base, which has all the healthcare knowledge to that. There is a tool repository, which is where you are building these tools, providing the guardrails, doing the orchestration, I think and then finally there is the integration repository, which is the EHR and the FHIR and all the security protocols that actually make the data safe. And then, if you really think about it, this whole DAMIA platform, prior authorization for providers is where we are starting. Payers and pharma are next, same on the prior authorization phase. But also, if you think about the continuum, we can continue to go and solve one Copilot at a time, different folks, different profiles and jobs in the healthcare ecosystem, and keep them making better and making sure we are amplifying their potential as they are working with AI. Thank you.
Are there any questions? I'd like to also just remind everyone if we could speak into the mic since we're recording. Let me know.
Hi, Christian Horn with Blue Venture Fund. My question is, what is your exact pricing model and how do you make money?
Yeah, what we are working with is at a physician level and at an enterprise level. So if it's an academic medical center, we will have a different kind of a pricing model, like more of an enterprise pricing model, versus if we go, as we are working with one of the healthcare distributors, going to the physician route, it'll be a different tiered pricing model for smaller offices.
Hey, just a bit of feedback as well. The prior authorization use case has been done to death. Okay? And it's a very, very congested marketplace as well. Yeah. So given that you have a Swiss Army knife approach, then extending out into some of the more challenging use cases, I think would resonate stronger and make you more distinctive and differentiated. Yeah,
we looked at the other comparators that are there. If you really think about what's actually going on in a lot of comparators, they are taking an RPA and an automation approach. Right? What they are not actually going after is solving the letter of medical necessity needs. It's actually kind of actually creating the materials that actually matter. So yes, I mean, there are a lot of comparators, much more automation focused rather than solving the clinical, kind of almost the clinical automation aspect and a more intelligent aspect. But point well taken.
Yeah, you can have the best solution in the world and be one of 1,000 and lose out.
That's a good point.
Okay, thank you very much.
Thank you.